Basically, after 9/11, I tried to enlist in the military, and my sister, being a recruiter for the military, laughed at me too, said your age and infirmities are a little too much. As a result, I started saying, can I give back in another way? I started looking at battlefield injuries and realized that most of our men and women come back alive, but dismembered. As a result of that, I started studying amputee problems. Most amputees can't wear their prosthetic most of the year, and their life associated with those prosthetics are bad. And I kind of had some ideas on how to make their life better. And as a result, that's where I'm here today. So, who am I? M14. I'll say the name of the company for later if you may or may not be interested. We are in the process of developing implantable orthopedic devices for amputees. I'm Larry Smith, President and CEO. Who are we helping? As I told you, it's amputees. There are about 600,000 people who live with lower extremity amputations every day. 40% of that population have difficulty using their prosthetic during the year. About 25% can't use it at all. Because of that, they lose productivity, they lose quality of life, they have difficulty walking and interacting. Once they get in a wheelchair, it's hard to get them out. What is the problem? The underlying problem is the inability to use the residual lower extremity, bone and leg, to perform its role. And what that leg used to do is act as a support system, act as a shock absorber, and an ambulatory mechanism. And we're asking something that's not capable of doing that to do that. So what are the problems that these amputees have? They have difficulty walking. If you ever watch an amputee walk, they have real unusual cadence. They have chronic pain from not only the surgery, but from the amputee prosthetic. They have recurrent infections, not infections in the way that you think, but the way prosthetics are designed to sit on the leg. They get infections above the amputation site where all the force and weight is carried from shear forces. And the current state-of-the-art systems, which are the trans-osseous cutaneous systems, carry about a 25% infection rate. So even still, 25% of people can't use them. So what is our objective? Our objectives are to improve the quality of life of these amputees, increase their productivity, reintegration into society, their ability to walk naturally, which is very problematic. Amputees burn a whole lot more energy walking than you and I ever imagined. We want to reduce their medical complications, and we want to create a new market for prosthetics that will generate and spread into other areas as well. What's our solution? It's kind of simple. You make the skin of the leg the heel, and you make the bone the calcaneus portion of the heel. We want to take residual bone so that it becomes weight-bearing and participates in ambulation. And how do we do that? What is our product design about getting there? And it's basically a prosthetic that sits on the end of the bone that is designed, and if any of y'all study fluid dynamics, you know the reason you can scuba dive to 100 feet is because we're mostly water. If you put 14 pounds of pressure on this side and push, you get 14 pounds of pressure on this side. Fluid's non-compressible. So taking advantage of non-compressibility of fluid in a container that sits within a fluid-filled compartment, we think we can transfer that energy from outside of the leg through the tissue to this, into the bone, back into the pelvis where it's supposed to go. And that will reduce a lot of the pain of walking, because right now, most people walk on the ischial tuberosity because the prosthetic that's designed rests on that bone. And you can imagine walking on your ischial tuberosity every day. It's not pleasant. So, what else do we want to try to do? With this, we want to try to mitigate skin breakdown by changing the shear forces and frictional forces on the skin, and improve the overall use of their lower extremity prosthetic, and improve their quality of life. And if we can mitigate any of those by 50%, we will improve their quality of life, which I think is important. So, who's going to look at paying for this? Why is this important? Key market payers, individuals. If it works, people can afford it, whether insurance companies pay for it or not, they'll go for it. 2, CMS. Medicare is always the big driver. If you you get a CMS approval, you get a CMS code, the others generally fall in line. Private insurance companies, VA, DOD has already been in conversations with DOD. DOD works a little different than most, as you know. And then, of course, international humanitarian and non-governmental agencies, healthcare agencies would be interested in this as well. Because kids walk around every day in Cambodia, Vietnam, Korea, Africa, step on landmines every day. They're still out there. So, sales and marketing, who's our target market? Who's exactly who you might think? Surgical residency programs, hospitals, trauma centers, orthopedic, trauma and vascular surgeons, DOD, VA, global medical NGOs. The goal here is, if this works, which preliminary data seems to be indicating that it will, it'll change the standard of care. Once you change the standard of care, then you're going to do it because it's the right thing to do. How are we going to market all this? We're coming to late phase 2 after some clinical trials have demonstrated some efficacy. By and large, I'm a believer in incentive. I like for people to work hard. If they work hard, they get rewarded for working hard. So I like commission-based type of programs. Market analysis, who's out there to help? It's about 600,000 existing, 30,000 new traumatic amputations a year. I want you to understand, these are just traumatic. This doesn't include cancer, peripheral vascular disease, diabetes, all the others. I'm just talking about traumatic amputations. Globally, there's about 1 million with 50,000 new amputees a year, probably more. I just included developed countries. When you start looking at market penetration, I figured we'd gain about 5% US penetration, grow about 5% annually. Globally, we have about a 1% market penetration, 1% annual increase in sales. If you look at the 5-year projections based on that, in 5 years, we're $213 million a year gross revenue. After cost of goods and services, gross margin at about 90%. General and accounting expenses, we end up with about a $72 million a year profit, and percentage of the market based on the actual head count. $72 million profit on 10,000 annual cases, pretty low. And bump up here is because we figure around the 3rd year is when the global market would become more available to us. What are the opportunities for this? Kind of broken down into some tranches. Right now we're working on an SBIR grant, the NIH, for $200,000. We probably could use about $500,000 total. We've got some matching. If we get this grant, we have matching monies from the state. Tranche 2 is about $2 million. Tranche 3, 6.5, 6.5. This will carry us through phase 1, phase 2 clinical trials. We believe in conversations with FDA and other experts that we can get a humanitarian exemption for this because it will be basically built out of medically accepted FDA-approved materials now. With that 510K approval, get our first sales started. Begin the construction of the manufacturing facility unless we choose to loan that out, so to speak, or license it out. Depends upon the economics, how it moves forward. Everything's negotiable. Expand our sales force, improve our board of governance, marketing, complete our facilities, and grow the company. Eventually, idea would be IPO. That again is like everything else in life. This is today, this is 5-6 years from now, hard to say. Everything's negotiable. So who are we? We were incorporated in 2012. We developed innovative orthopedic devices. We received the phase 0 grant from the state for this. We have several patents pending that are related to this development. And we basically have several other prosthetic assist devices that are in the pipeline. We have I'm the president and CEO at this point in time, principal investigator, a retired physician. Been a bank director, developer, entrepreneurial for some time. I've written several books, like publishing. Have had a lot of entrepreneurial experience with other businesses. Cameron Knott, who is my co-investigator, is a University of Florida graduate. He's an engineer at Orbis Company right now in South Carolina. He and I work together on this from conception. I have a scientific advisory board based on some people here locally, all of whom are engaged. And I'm currently also working with Exactech, who's an orthopedic appliance and implantable joint company here in town. And that's how you can get in touch with me. The name of the company comes from the fluid dynamic aspects of walking on water, because when we walk, we literally walk on water. We do not walk bone on bone, cartilage on cartilage. So I borrowed Matthew 14 from the Bible as the name of the company. So this ergo M14 2233 LLC. And I always get asked that, so I always explain it up front. And with that, that's my company and what we want to do. Questions? Yes, sir.
The patent position, I mean, what is the patents around?
The patents centers around the device itself and how it interacts, how it's attached to the bone, the form, shape, function of the prosthetic, and how it will work in the long run inside the patient. We have several iterations. The first drawing that I showed you there is far from where we are now, but it seems to be the simplest for people to suddenly get a concept of. So that's why we put it there. But we actually have 2 more patents for the testing platforms, because where we are with this is kind of groundbreaking. There's no data that says if you do this, this is what you get. So our normative data that we're comparing to is artificial hips, knees, shoulders, and the force and wear structures and machines they use to test their instruments. We're actually having to make. And that's been exciting too. I mean, this is the thing that's kind of a love of labor and a labor of love, and as it turns out, looks like it may have some significant impact. And again, you know, the goal would be to take these patents and get rid of all those problems. Having been in medicine long enough to know we may not mitigate all the problems, but if we mitigate them by 50%, that's huge. That's really huge.
So who would you describe as your competitors?
There is one. Actually, I have looked and looked and looked. If it works, it's a monopoly. I mean, I don't want to say that in an egocentric way. There's just nobody that makes it. So we would have patent digital in 20 years. And 20 years of short of Chinese competition, relative non-competitive market, which is good and bad. I mean, it puts obligations on you as the producer to be fair and provide services that are good for the community and society in general.
What would your clinical trial path look like? I mean, do you go to animals? Do you go to...
We've looked at animals. There isn't, that's the problem. You know, have dogs and cats. What happens if you cut off one of their legs? Do they miss it? Yeah, they don't even miss it. And that's the problem we've had. We don't have a good animal model. The closest model that we could think of would be horses. And evolutionarily, that's because horses walk on, you don't know about homeboard if you know this. You know, they walk on a finger. Their hoof is their fingernail. So horses walk on one finger. That's why they put them down after they break their leg. I don't particularly want to raise horses to cut part of their leg off and put this on there. But, you know, if that's what the FDA requires, then maybe what we have to do. The problem is, y'all know, horses are big, they're expensive. They take a lot of money, and you can't breed them like rats. So animal law is a problem. So I think through humanitarian exemption, because actually every amputee I come across, I walk up to and introduce myself and talk to them about it, get their name and number. Uniformly, every one of them volunteers. It just, wow. It blows me away.
How much higher proximal, distal to proximal do you have to go to take into account the size of the device in terms of where you'd actually be cleaning the femur to make that attachment point?
Well, you know, at some point in time, it gets to the point where it's easier just to do a total hip disarticulation. But I'm thinking mainly from bottom, lower 2/3 and down. The real challenge is going to be in the transtibial resections. That's where we're really spending some time doing some engineering. That's going to be neat if we can improve their lives. But for the femur, anything short of, anything longer than a third of the femur, I think, would work, because you'll have room to put an external prosthetic on. Does that answer your question?
How far along do you think you are?
Oh, we've got prototypes we're finishing up now. We've got our static test platform built, and we're building our dynamic test platform. We'll have 3 different prototypes probably in the next 3 weeks. I was going to bring one today, but I said, no, let's wait.
And your means of attachment to the bone is just fixation?
Yeah, it's intramedullary screw. You know, orthopedic guys love nails and hammers. And so this would, you know, it's not going to be a hammer that you drive a pin in like you do for most kids. This will actually probably be a self-tapping intramedullary screw. It's hollow, allows for cortical bone and growth, and so you can get strength. That's the great thing about bone and why this is so neat. Bone is funny, the more you load it proximal to distal, the stronger it gets. The more you load it laterally, the weaker it gets. And so in consultation with Exactech, they feel an intramedullary screw would be outstanding in terms of generating force. And we thought about failure too. I mean, they're going to fail because of just the nature of the design. So we've designed it modularly. So you can, once you put that intramedullary screw in, you won't leave it. But if they damage it, or they rupture it, or they break it, then you just go in, you take off the external portion outside of the bone, put in a new one, close up the wound. And all this can be done as outpatient. Then you have prior hospitalization on the wound.
And just out of curiosity, you have this liquid-filled bag. Do you wrap that with muscle? Do you pull the muscle down around it?
Yeah, right now that's how most wounds are closed, is you take the residual muscle, the tissue, and you close it around the end of the bone. And the skin, when you close a wound, you don't want to close the scar right over the bottom of the wound. So you actually create a flap that sutures closed on this side. So our goal is to take advantage of that tissue between the edge of the bone and the skin with this prosthetic, but again, realizing 90% of that tissue is water. And if we can build on that concept of energy transfer through non-compressible fluids like the brakes on your car, you know, why can your foot stop a 2,500-pound car? Because that fluid is so strong when you push it through that pipe into those cylinders, it stops the car. It's kind of the same thing here. It's actually going to kind of exciting. Other questions? Beat me up. I really, the more y'all question, the more I learn too. That's quite right.
Is it sailing in the capsule?
Trade secret. Trade secret. I learned about patents too. Patents are good, but trade secrets are better. I didn't mean to be rude with that, but it's
your investors will appreciate that.
Yeah, yeah. Patents are good, but trade secrets are better.
Financial needs over, what does the next 6 months, 12 months look like for you ideally? I know you went over that, but what,
you know,
where's that money going?
I was on the phone with NIH today. This is my second shot, my first NIH grant, second shot at it. Basically, you know how they score NIH grants? You know, they score everything, and they take like the first third, and the middle third, and the bottom third. The higher the score, the further up you are, the less likely you are to get funded. And I fell on the short side of the middle third. Not because it wasn't a good idea, because everything rated high there. They weren't sure how are you going to test this. So I was on the phone with them today going through how we actually plan to test this. And I know the NIH guys aren't going to say, we guarantee you get it, but they say we like it, it's innovative, you're going to probably be in the running. So I need to hit the top 40th percentile. And I think we will. So I think that first tranche, $200,000 from the feds and then the matching funds from the state's pretty good. And I've got my own capital that I've invested in this as well. So this phase, we're really not doing too bad. Phase 2, if this works, again, NIH is going to have $3 million available for it, and DOD will probably throw some money in there too. And this will be kind of the exciting phase. You know, again, 2014, 2015, our projections, and as you guys know, the FDA, because I'm assuming some of y'all have done some kind of devices, the FDA can be very accommodating, or they can be very problematic. And it depends, I guess, upon how the system works. But I'm thinking that's about a 2-year cycle, which is around a $2 million tranche for that. This will probably be the biggest question, because if we get this early, and it shows early clinical efficacy, that will accelerate this phase, and that will bring this money into place sooner. So, you know, you never say no to money. You just have to kind of, again, weigh the value when and where. if that makes sense. That's the motion.
On your patents, have you gotten to the publication phase yet?
Trying to hope I get a lot more done before it gets to that phase, but I think that occurs usually about 9 to 12 months after your submission. So
It's 18, is it?
yeah, well, 18 is even better.
Have you gotten any office actions yet for anything on that?
We have not gotten any office actions, although we've been in touch with them, and they say it's 12 months. You know, I was just talking to a patent guy upstairs. In spite of Uncle Sam's desire to do well, they always tend to make it harder. But you know, I'm almost at a point where I hope it kind of sits there a while, because I'm protected, because it's been submitted and received. And the longer I have time to prove it, the better off I am, because I think then, you know, I'll be able to say, well, you know, we have proof and we have a patent, because, you know, the new laws are first to file. You know, some guy can spend 20 years of his life researching something, and some guy filed it a year before he publishes anything, he loses out. That makes a motion. That's not what I'm hearing. Other questions?
Is this the first product you've taken to market? Do you have others that you've?
You know, I've never taken a product to market. I built a medical practice from a single man group to a 10-member group with office space. Millennium Center was my project. I had done Millennium Center built that we occupied. Millennium Bank that was there, I was a founding board member. We took from a $7 million investment to a $5 billion investment. It's now owned by PNC out of Philadelphia, Pittsburgh area. Started some small businesses that did well during my medical practice, and generally kind of been a quasi-entrepreneur all through my life, from cutting grass and delivering newspapers to doing this. So as far as products, this will be the first product, but it's a good challenge. And with the right people, because nobody's going to do this by themselves.
Do you anticipate bringing anybody else aboard in the near term?
Absolutely. Yeah, I think it'll have to be. You know, I know from building a practice, building a bank, running businesses, you bring on good people. You pay them in the top 95th percentile so they don't want to leave because there's no place left for them to go. You delegate to them, you trust them to do a good job, and until they prove otherwise, you let them work. That's kind of my approach. I guess it's more the Eisenhower approach to good man. If they do a bad job, slow to hire, quick to fire. Other questions? Come on, I'm happy to answer them. I've learned more from y'all asking me than I think sometimes I convey. What's the downside? You guys must see some downside.
Yeah, who doesn't this work for?
Again, I'm sorry, I didn't hear you.
Who doesn't this work for? Which category of potential patients, of amputees?
Probably upper extremities. That's a little bit different problem. Because you're not really carrying force and weight bearing. So probably upper extremities. But we've got some twists on that as well. Because some of the other products that we have in line are unique ways of holding the external prosthetic on. Again, if you study the history of prosthetics, this sounds terrible. We aren't doing amputations any different than we did them 500 years ago. Fighting in the battlefields when Napoleon and those guys were whacking arms and legs off. And we're not making prosthetics, external prosthetics, any different than the ancient Egyptians did. You can see the hieroglyphs where they were making them. And so, honest to goodness, I just stepped back and said, we got to do something different because these people are not achieving the quality of life they deserve. And ergo, these ideas came about, and even new ways to hold on. Unfortunately, I had the advantage of having done a lot of amputations in the past as a surgeon. I look forward to doing an amputation, don't get me wrong. I kind of understand the problem from that point of view as well. That answer your question? Good.
Have you talked to DARPA yet?
DARPA, I've been in touch with DARPA. DARPA's funny. DARPA, it's not kind of, this is more DOD thing. You're talking with NIH and those guys, and DOD is going to say, how I understand it works. We need X, Y, and Z. And I would bid out a contract with them and say, I can give you X, Y, and Z, and they'll sign a contract and I'll produce it and they'll buy it. DARPA, you know, they're looking for things kind of down the road, you know, that you can really either detect the enemy or kill the enemy or, you know, protect their wounded soldiers in terms of getting them off the battlefield robotically. They've done a lot of neat stuff. This kind of falls into the MASH unit area. By the time you get the kids back there, or the person out of the motorcycle wreck, or out of the car wreck here, you get them to the hospital. That's kind of when the value of this kicks in, which is hopefully good. And we do have a publication that just got accepted in military medicine on this. I should have mentioned that earlier.
Have you looked at any, and I feel the same way how you mentioned about the amputations. You're fortunate that you have that experience and didn't look forward to them. You definitely hate the fact that this is a reality, but what is the lifetime cost comparison when you deal with the traditional, the steady state of the world to your method? Obviously, upfront costs have to be a little different, but then ongoing treatment?
That's the excellent question. Right
I have
now,
one a day, so I'm glad I got it out of
you got it. You really hit part of the nail on the head. Amputees end up over the course of their lifetime getting 15 or 20 new prosthetics made because physiologically the skin, the muscle changes all the time, the fit changes all the time. So the cost of maintaining the prosthetic is more expensive than losing the leg. You know, losing the leg, honestly, I don't mean take the sound of it, you can take a leg off, you know, in just a few minutes. And you're out of the hospital fairly quickly if that's your only injury. Then, Medicare is constantly paying for new prosthetics, Blue Cross is paying for new prosthetics. So they're looking, that's why they're listed as #1 payers. They're looking for something that will at least stretch those revisions out or eliminate them altogether.
That's the real cost driver in care is in this case, far more significant.
Yeah, and that's a great question to ask, and I'm hoping that if we mitigate a lot of those problems, that will become the big, because then they're happy to pay up front. They'd rather pay a little more up front to save in the long run.
Sure.
Thank you very much. Thank you. No, thank you. I enjoyed it. Thank you.
Good luck with it. It's very interesting.
Well, thank you. I'm excited about it. Probably maybe a little too excited.
Never too excited.
Never too excited.